My name is Steve Kleibacher, Chief Scientific Officer for Eurofins US, and we're going to talk today about a paradigm of precision medicine. We'll break it up into two separate parts. First about CMV Insight, T-cell testing, and then my colleague James Fleming will talk about TruGraf gene expression testing. Okay, so first about CMV specific monitoring in kidney SOT recipients. So our assay is a CMV Insight, and this is a flow cytometry-based assay that takes fresh whole blood from patients. We split that sample into 4 aliquots, a negative control, a positive control, and then 2 aliquots that are stimulated with CMV antigen. We then incubate overnight and then do standard flow cytometry staining for CD4 cells, CD8 cells, and then interferon gamma production, and we report that as a % of cells expressing interferon gamma. The idea of immune monitoring for CMV management has been around for quite a number of years. There's probably literally 100 publications out there going back about 2 decades. It's mentioned in a number of reviews and guidelines. I'll just point to a few here initially. This is from the Cotton et al. Third International Consensus Guideline for Management of CMV. And immune monitoring is specifically called out in a number of different settings. I like this table, the summary table here, because it does point to the use with viral load monitoring, especially in the post-transplant period. But just picking the post-transplant prophylaxis there in the center, I'm not sure I have a pointer, but in the center, if a patient's positive with CMV T-cell immunity, then that's an indication that prophylaxis can be stopped. If they're negative, the recommendation is to continue prophylaxis, or if it's time to stop based upon the prophylaxis period, then monitor those patients with greater frequency in the surveillance. There's a number of different use cases laid out for the treatment, the asymptomatic R-positive patients at the end of treatment. Here's where the viral load monitoring comes in. Patients, for example, that are positive but still have a positive CMV T-cell immunity, they do have immunity, and so you can consider stopping treatment with those. Now that's very viral load dependent. As anybody who knows who's treated patients, a few hundred IUs per mil is quite different than a few thousand IUs per mil. There are a couple of recent review papers that specifically looked at clinical utility and validation of CMV-specific immune testing. This is a paper from 2020, and it looked at a couple of different methods that are used. So I didn't mention earlier, but there's really 3 methods. The first that this looked at was the ELISA-based method, which is a quantiferon type method where interferon gamma is measured in the supernatant. And then the second they looked at was the ELISpot method, and it was a systematic review, and overall they found that their data showed a promising role for interferon gamma. In this case they call it release assays, but essentially interferon gamma assays for the adjustment both of the duration and the prophylaxis for CMV prevention. The second review from 2021 looked at these 3 methods I just mentioned and pointed out some of the advantages and disadvantages of each of the 3 methods. One that I want to highlight is the flow cytometry method that we use, the CMV Insight, allows differentiation of CD4 and CD8 T cells. If you've read the literature, in general, the CD4 CMV response is more predictive of the protection against CMV than CD8. CD8s are not unimportant, but they're not the main driver of protection. But these authors concluded that there was compelling data to support the role of CMV immune assays in the management of CMV infection of SOT recipients. And then recently, CMV stewardship programs have been established. This group at University of Wisconsin is really leading the way in this and has published a couple times on the gold standard for CMV management. And this is a flow chart that just looks at the management of the high-risk patients in solid organ transplant, the D+, R-. And I won't go through each of the boxes, but you'll see at the bottom, they recommend testing the CMI, or cell-mediated immunity, for CMV at 9 months. And then if positive, the surveillance is complete. You can discontinue the qPCR every 2 weeks. These patients are considered to be immune, and they recommend unenrolling these patients from the CMV stewardship program. And then conversely, if the patient's negative, they recommend continued surveillance of these patients. Again, in most scenarios, it would be every couple of weeks with qPCR, and they recommend doing that for another 6 months. So the guidelines to use these assays are certainly emerging, and they are based on quite a bit of data that's been published over the years. This just shows a list of recent publications that have used the CMV Insight assay. I won't go through each of these. In general, they've shown a PPV of about 85 to 90%. And PPV, the positive predictive value, that's defined as CMV T-cell immunity present, and then no clinically significant CMV events, so no viremia that required treatment or tissue invasive disease. The negative predictive value is a bit more modest, negative being a patient that doesn't have immunity but does get CMV. The reason that's more modest is that the false negatives are considered patients who didn't get CMV, and even in the high-risk group, we know that not every patient gets CMV, so the prevalence is typically about 30 to 40%, and that does drive down the negative predictive value a bit. But again, we focus on the positive predictive value of this assay. Now, this last citation is still in review, so I'll go through a few of the key findings with you. This was an interventional study, a prospective interventional study that we conducted in collaboration with a group at University of Nebraska. A few of the significant patient demographic values. First of all, these were D+R- kidney recipients, all on CMV prophylaxis. We started testing the CMV T-cell immunity panel at 3 months post-transplant and then monthly until 6 months. This center provides prophylaxis for a full period of 6 months, but in this study, they discontinued the use of prophylaxis once the patient showed a CMV CD4 value greater than 0.2%. The median time to the first positive result was 4.4 months, so on average, each patient that was positive saved about 6 weeks of prophylaxis. These patients were prophylaxed with ganciclovir, by the way. So in the chart on the right, you can see at the early termination of prophylaxis, there were 23 patients. Most of these patients were were R+, a few were R-, and then most of the R+ patients had depleting induction. So at this center, you may ask why they provided 6 months of prophylaxis for R+ patients. That was for depleting induction, and again, those are more intermediate to high risk and similar to the D+R-. But most importantly, in the lower right, is that the patients with early termination of prophylaxis, again, there were 23 of them, none of those patients had a significant viremia, and none of them had tissue invasive disease. They did have number 14 out of the 23 that did have viral blips that were detected. These were all less than 1,000 unit IUs per mil, and therefore did not meet that38 threshold for treatment. But contrast that to those that did not have the early termination of prophylaxis, 38 patients, and you can see there was quite a bit of both tissue invasive disease and positive viremia. About a third of those patients had either clinically significant viremia or tissue invasive disease, and then another few patients had positive viremia. So good p-value there, and shows that this can be used to safely end prophylaxis early in intermediate to high-risk patients. So I'll spend the last couple of minutes talking about interpretation of results. As I said initially when I talked about the flow cytometry method, we report the percent of interferon gamma positive CD4 and CD8 T cells. So you can see in the center column the result for this example. This patient had 1.38% of the CD4 T cells positive for interferon gamma after CMV stimulation, and 0.4% of the CD8 cells positive. These were both above the reference range that we've established, and actually has been independently validated by some of the studies I showed you on the bibliography slide. So this patient had a positive CD4 and CD8 T cell response. Now you'll note that I also show the positive controls, the SEB or the staph enterotoxin B controls. Those are important. These are highly immunosuppressed patients in many cases, and if they don't have the ability to respond, then it's difficult to interpret the results, and we have to typically wait for another sample. In this case, the patient did have a robust SEB response for both cell fractions, so very straightforward interpretation there. And then this is a live cell assay, so we also measure viability. But based on these results, this patient, as I said, has both CD4 and CD8 CMV-specific immunity, so this would be the lowest risk category, a patient, for example, that could be withheld from treatment, assuming the viral load was reasonable, or perhaps could be a candidate for early termination of prophylaxis. This is a patient that doesn't meet the threshold for either CD4 or CD8 cells, does have the SEB values above the cutoffs for the reference population, and does have good viability. but the lack of a positive stimulation in either cell population, CD4 or CD8, puts this patient at the highest risk. So again, thinking about that end of prophylaxis period, or perhaps a patient that is starting to have some viremia detected, this would be a patient that would either need to be monitored closely every couple weeks with a CMV qPCR assay, or perhaps even more frequently depending on other risk factors, or started on treatment, secondary prophylaxis, whatever the stage of the patient was post-transplant. And then this table just looks at the clinical interpretation by patient status. We provide this to the physicians to help them understand how to use the assay. So in that first group, we have D plus R minus patients on primary prophylaxis, R positive patients with high risk factors such as depleting induction, or CMV treatment with the risk of relapse. And here, if the patient is negative, the CD4 value is less than 0.2%, then either continue the prophylaxis or do frequent viral load monitoring. Positive, on the other hand, these patients are candidates for stopping the prophylaxis and less frequent monitoring, as you saw in the University of Wisconsin's CMV stewardship guidelines. If there's low viremia with no clinical signs, again, negative, typically these will be started on some sort of treatment or secondary prophylaxis. Positive, then just viral load monitoring is all that most programs are using. And then finally, patients that are treated for rejection with increased immunosuppression, these patients do need to be retested with CMV T-cell immunity. We've seen a number of examples where patients go on treatment for rejection and then they'll have CMV in that period afterwards, even though they were previously immune. So that does tend to reset the immunity status of the patient. So in summary, the applications of this assay are at the end of prophylaxis, assessing risk and frequency, the needed frequency of subsequent viral load monitoring. Patients in which early end of prophylaxis would be beneficial, for example, due to toxicity problems. Assessing the need for treatment in patients that have viral loads that are near the cutoff. Most programs treated 1,000 IUs. What about that patient at 800 or 900 IUs? At the end of secondary prophylaxis, to determine if they need to extend that for a longer period. And then finally, determining if that's even needed after you've treated a case of CMV. So I'm going to stop there, turn it over to James, and I think we're going to take questions at the end so we don't run out of time.
Thanks, Steve. All right, thank you, Steve. Great talk. So my name is James Fleming. I'm the Director of Medical Affairs and Clinical Trials at Transplant Genomics. And I'm going to talk a lot more about TruGraf in this talk, but I will also be talking about tract donor-derived cell-free DNA as well. So I think it's important to really take a big, wide view of kidney transplant, and I think that we can all agree that we've seen an improvement in graft survival over the past couple of eras, especially in living kidney transplants. You can see that it's substantially improved. However, we are still losing allografts, and for multiple different reasons, and the reasons I think have changed over time. We're still having to provide 13% of transplants every year to previous transplants that could go to people that have never had a transplant before and help decrease the wait list. I also would argue that, in terms of just looking at overall graft survival, that sometimes all that glitters isn't gold. So you can see here the changing proportions of people and how they're losing their grafts. Whereas we've improved our death-centered graft failure rates over time, we have more people dying with a functioning allograft at all time points post-transplant here. This is a combination of a lot of things, including the people that we're transplanting as well as the immunosuppressants that we're providing them. In addition, when you look at the actual graft function of these patients, at a year, only 30% of deceased donors have estimated GFRs over 60, and only 40% of living kidneys have estimated GFRs over 60. So we have a lot of room for improvement even there. So, although we have done a really good job of improving, early rejection rates that have led to some of these improvements in death-centered graft failure, we're still losing a lot of people. We're losing a lot of deaths for a lot of patients to cardiovascular deaths, infections, and malignancies. We also, on the flip-hand side, those people that are losing their allografts, the vast majority of them are losing it to rejection. So we're kind of caught between a rock and a hard place. And I think that's an important thing when we're talking about biomarkers, is that we have two different targets that we're trying to target here. Both immunologic as well as over-immunosuppression, and really trying to find that happy medium, and that personalized medicine is where our target has to be. I'd also say that, just thinking about the way in graft function, that there's a real continuum between the time of transplant all the way to the graft failure. And you can see that borderline rejection, inflammation, T-cell mediated rejection all come early, whereas antibody mediated rejection tends to be more of a terminal event or a counter much later within the progression of the kidney transplant. And I hear people say that all I care about is antibody mediated rejection because that's what people are losing their grafts to. I don't care as much about T-cell mediated rejection or subclinical rejection. And to me, that seems analogous to me saying I care about heart attacks, but I don't care about how you eat or how your physical activity levels up until the time point of that. So we see a relationship between immunologic inflammation that then can develop into de novo DSA or T-cell mediated rejection on the progression along the way to all the things that are causing our graft failure, whether it's antibody mediated rejection, T-cell mediated rejection, or even the chronic scarring and chronic of grafts over time. And so, the old adage still works. An ounce of prevention has to be worth a pound of cure. And we just have to really show that and use biomarkers to help implement interventions earlier on. So the two diagnostics that I want to talk about here are TruGraf and TRAC. So TruGraf is a gene expression profile test, and what it does is it measures the gene expression at the time of subclinical rejection on biopsies. That's the way that the test was developed. I would also argue that what it does very much is pick up that subclinical inflammation. And sometimes it doesn't, as the test has matured and we've seen it applied within patients, I'd argue that sometimes you don't always see that injury on the biopsy. But that doesn't necessarily mean that it's not there, that it's not causing some of that scarring. On the other hand, we have TRAC, donor-derived cell-free DNA. Now this is a measure of injury. So it's very much more reflective into what you see on the biopsy, especially at higher levels where you see a lot more damage. So we have two different markers that I think can fulfill a lot of two different roles within the monitoring of kidney transplants. We also know that they tend to detect different things by nature of what they're measuring. So TruGraf is a lot more sensitive to T-cell mediated rejection, whereas TRAC is a lot more likely to be positive than antibody mediated rejection because that's where most of the damage is. So the couple papers that I want to talk about today, the first one being one from the Mayo Clinic. So this is a multi-center prospective observational study. So they drew samples. They did not have results, so they didn't interact with these results. It was all observational. But they enrolled 240 subjects that they were able to follow for a median of 3.8 years. And they drew TruGraf samples and did biopsies within the first year. The TruGraf samples were at months 1, 4, 6, 9, and 12, and the biopsies were at 4 and 12. The primary endpoint that they wanted to evaluate was patient and allograft survival, which is why their follow-up was a median of 3.8 years. But they also wanted to look at one-year outcomes, early outcomes, estimated GFR, IFTA, moderate to severe IFTA, or development of de novo DSA. And what they saw is that, as you can kind of see here, well, first things first, because this is an observational exploratory study, they divided the cohorts based off of gene expression profile phenotypes. So those that, out of all the tests, were completely negative, they called a TX. Out of those that had all these tests across the first year and only had one positive or one not TX. And then anybody that had more than one, of course, went into the more than one not TX group. And you can see that in addition to seeing some differences, especially between the more than one not TX and the TX in rejection, primarily you can see a graded significant difference in both the one not TX group and the greater than one not TX group in terms of both estimated GFR at a year, as well as moderate to severe IFTA. The next thing that they evaluated was the time to biopsy. And so one thing that I think that is interesting here, and I think was a important point, is that when they did this analysis, they only accounted for rejections that happened after a patient met criteria for that cohort. That way you're not looking at rejections that happened before they had more than one NOT-TX, right? So we want to look at this as more of a predictive of a risk of rejection compared to rejection that's already kind of happened. And you can see that those patients that have more than one NOT-TX, more than one positive test, their rejection rate was significantly higher than both the other two cohorts, which, of course, goes along with the decrease in estimated GFR we saw before, and the hypothesis that I put forward previously, that whereas it may not always be rejection at the time of the positive test, that more than one positive test does seem to represent subclinical inflammation that then can become rejection over time. And then finally, their primary endpoint was the death patient and allograft survival. And they did see that there was significantly better death-censored allograft survival in those that had no positive tests or just one positive test as compared to those that had more than one positive test. And so they concluded that multiple positive gene expression profile tests could be an indicator of an activated immune response, resulting in persistent or recurrent inflammatory damage that then led to the short-term and then long-term outcomes that you saw in this study. The next study I'm going to talk about is something that was presented as a presentation at ATC in 2023. This was a planned interim analysis of the TruLo study. This is a large observational multi-center study that we have going on where we enrolled over 2,000 subjects. It had been planned that we were going to analyze some outcomes at once at least 250 subjects were followed for at least 1 year. Well, at the time that we pulled the data, we had 589 subjects that had at least 1 year of follow-up, and that was what this analysis was done for. You can see the demographics here. And one of the things we wanted to evaluate is further look at what we think is kind of, that important relationship in renal function. So how the graft is actually functioning, not necessarily looking at, rejections, but how the graft is doing. And you can see here that using those same cohorts that we had that had been proposed by the Mayo group, we saw that there was a significantly greater decrease in slope over that year of follow-up in anybody that had one positive test compared to no positive test, as well as two or more positive tests compared to no positive tests. The other important point about this is that whereas the Mayo group was looking at the 1 year test results, the median time of enrollment into this study was over 4 years post-transplant. So this indicates that relationship between gene expression profile tests and then the resulting renal function impact is not just limited to early patients. The other thing that the statisticians saw that was very interesting, they felt, is that the effect on renal function seemed to be most significant in those that had the highest renal function when they got enrolled. So the impact on having one or two or more NOT-TXs was significantly more impactful or a greater decrease in those that had started with a baseline estimated GFR of over 80. For instance, one NOT-TX dropped them by 4 mils per minute, and then two or more, they had an average decrease of 13 mils per minute in that 1 year follow-up. So the conclusion was that the multiple positive tests as modified by estimated GFR was associated with a greater decline in renal function. And again, this supports the theory that the TruGraf gene expression has utility in chronic surveillance and could be a prognostic test for clinical outcomes, especially GFR. The last one that I'm going to talk about, because I know that we're also falling quite short, is a poster that was presented at ATC last year. This is an interim look at an ongoing randomized study. Dr. Petty in San Francisco is performing this analysis where he's enrolling subjects and then randomizing them at 3 months post-kidney transplant into a immune minimization intervention using TruGraf tests versus a cohort where they're not making any interventions at all. You can see based off the inclusion criteria, these are very low-risk patients that he's including within the study. So the way that his intervention works is that at month 3 they get a TruGraf. If that TruGraf test is TX or negative, then the MMF gets decreased by 50%. Then they do tests at months 4, 5, and 6. If all of those continue to be negative, then the TruGraf goal goes down to 3 to 6 compared to 6 to 10. Then they have 4 more tests over the follow-up just to make sure that these changes haven't caused any kind of subclinical inflammation that would be picked up by the TruGraf. And what he's seen so far, at this point, they've fulfilled, at this point I can tell you that they've fulfilled enrollment and randomization, but of course this abstract was, a year ago. And so there were some very, early results that he presented. I would take you to the 12-month results on this slide, where 13 of the subjects were in the study group, whereas 6 were in the control. And you can see that the TACRO level and the estimated GFR are visually different between the 2 groups. There's no statistical analysis here, but they do visually look different, whereas the TACRO level is quite a bit lower in the study group, as well as the MMF dose is about half of what the control group is. And you can see about a 6-point difference in GFR. And so we're really looking forward to the ongoing analysis of this and what the results will look like. So just to recap, subclinical rejection inflammation occurs on average in 25% of patients. And thinking about the 2 sides of our problem, both over immunosuppression and under immunosuppression, knowing patients that are free of that subclinical inflammation or subclinical rejection, I think can give a lot of peace of mind, and it also can give us some power in managing these patients that could be at risk of many of the things that are causing mortality in our patients. Early intervention, we do think is going to be able to prevent worse long-term outcomes in terms of terminal events with graft failure. And then the 2 tests used in combination could have some potential ability because they do detect 2 different things and they detect different types of rejection. And so at this point, I'd be happy to take any questions for either Steve's excellent talk or ours.
Rejection. I'm sorry. You mentioned repeating the CMV assay after treatment for rejection. Any guidance on a timeline for that?
Yeah, generally about a month. So you need to wait until that that period closes out a bit. But
Sorry, on the CMV. What's the guidance for when, the CD4 is positive, the CD8 is negative, in making the decision about how to go forward?
yeah, that's a good question. So as I said, most of the papers, if you just look back over 20 years, the CD4 component has been more predictive of protection. The CD8 component, however, in 1 or 2 studies where they looked at the timeline, they actually see that coming up early. So generally, if you have CD4 positive, just call those positive regardless of CD8. If you have CD8s positive, they're more in that intermediate, that gray area. The AUC is not quite as good for the positive predictive value or for the diagnostic performance. But wait about a month or 2 and then you'll often see a CD4 positive. If you don't, then it's probably not going to emerge in the patients. Strangely enough, some of them just never develop a CD4 or CD8 CMV response. I don't know if it's anergy, burnout, senescence, or what the problem is, but that's fortunately not a huge number, but it does occur.